or I'll just see whether I can WhatsApp you or not.
Sunilji?
We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 260. And now we start off with our Uvea series, and this is the first session of Uvea series. Today we have with us Dr. Parthopratim Dutta Majumder sir from Nethralaya, Chennai, and he will be starting off the sessions with anatomy and physiology, applied aspects in uveitis. And I request our chair for the evening, Professor Amod Gupta sir, to please introduce Parthopratim sir. And we also have with us Dr. Abhilasha Baharani ma'am, who is also going to help us out with the moderation.
Well, friends, good evening to you all, and anywhere in the world where it might be good morning. I think it's a great pleasure to chair the first session of a series of lectures. I think these are 30 lectures which are going to be delivered at the same time on each Wednesday or Friday till 15th of March. So be ready for a series of these lectures. It's a course designed beautifully, I must say, on a unique courses. And as you know, that online iFocus is a very, very popular teaching program in the country for the benefit of the residents and practicing ophthalmologists who may like it. So we'll roll off with a lecture by Dr. Parthopratim Majumder. He is a senior consultant at Sankara, Nethralaya, Chennai, and we all know he's popular all over the world for running a very, very interesting website, which is very educative material on this website, eOptha. So here is Parthopratim giving us the salient features of anatomy and physiology of the eye, relevant to the field of uveitis and intraocular inflammations. And my request to the occupants of the hot seat are to interrupt Dr. Majumder and make it more interesting and interactive. And I have already requested Dr. Partho to go a little slow so that everybody can catch up with what he's. And we have ample time. I think 1 hour for each lecture is a good time to imbibe the information. So we don't want to have information overload, and we want to go a little slow on that. With this, I'll invite Dr. Partho to start his lecture.
Yes, sir.
Hi, I hope you can hear me also.
Yes, sir.
So, good evening, friends. Thanks, Professor Gupta, for the kind introduction. So, friends, I sincerely thank Dr. Santosh Honavar and team iFocus for giving me the opportunity to be a part of this fantastic Uvea module. There are some 30 comprehensive topics in this Uvea module, which will be covered over a period of time. So, my talk is on applied anatomy and physiology, which has been prepared aimed at our postgraduate friends. So just a disclaimer, the diagrams which I'll be using in this presentations are drawn by me just to simplify the various aspects of the uveitis. So the quality of those line diagram or the images may not be like that of the professional artists. So I hope you will understand that. And as Professor Gupta mentioned, that you can interrupt me, those who are in the hot seat, and can ask any question or query if you have. So to starting with, the name, the origin of the uvea actually comes from a Latin word called grape. Now, question may come that why grape? So basically we feel that probably they thought that if the stem is removed from a grape, then the hole looks like a pupil and the grape is the eyeball they wanted to compare. So that's how it is named as Uva, and from that Uvea. So as you know, that eyeballs are comprised of 3 layers, namely sclera, and the cornea forms the outermost layer. Next, the middle coat is the uvea, and the innermost, the sensory layer, is the retina. Now, this uvea consists of a highly pigmented vascular layer composed of heterogeneous types of cells, namely mesenchymal cells, which includes fibroblasts, melanocytes, and the vascular supporting cells that mostly arise from the neural crest, that is mesoectoderm, but also some component from the mesoderm. Now, there are 3 parts of the uveal tract. The first one is the iris, which is the diaphragm of the eye, regulating the light that enters the eye through the pupil. The second one, the middle portion, is ciliary body, which is essential for lens accommodation and aqueous humor formation. The most posterior and the largest portion of the uveal tract is the choroid, which provides the nourishment of the outer retina, especially the macular region, and regulates the ocular temperature, which is very important. Now, coming to the iris, iris is a cone-shaped structure. The pupillary margin of the iris, if you see, it rests on the lens and slides over it during the movement of the iris tissue. Now, this root attaches to the anterior surface, or you can call it base of the ciliary body, and this root is the thinnest part of the iris. Now, there are 2 implications. As you see that the iris rests on the lens, without the support of it, for example, in aphakia patient, the iris becomes tremulous, and we call it iridodonesis. And then sometimes what happens when there is any injury, so there will be tearing away of the iris from the ciliary body. So we call it iridodialysis. Now let's talk about the topography and the anterior surface of the iris. Perhaps all of you know that the normal image of the iris, what we see, is actually magnified by the 1/8, since the cornea and aqueous acts as a plano-convex lens. Most probably you'll be happy to know that this was first described by Helmont, the man who invented the slit lamp. Now, coming to the anterior surface of the iris, it has an arbitrary circle named collarete. So this collarete is basically a circular ridge lying about 1.6 millimeter from the pupillary margin, and this arbitrary circle divides the anterior surface of the iris into 2 zones. The outer one is called ciliary zone and the inner one is called pupillary zone. So now the anterior surface has certain characteristics. For example, the anterior surface is characterized by the radial streaks. These streaks are straight when the pupil is contracted and wavy when it is dilated. And there are certain contraction furrows, which is noticeable mainly when the iris is dilated. You can see here, I have marked with the line diagram that which one is the radial. These are the radial streaks you can see here. And these are the contraction furrows. You can see here one more. So these are the contraction furrows. We can see them only mainly when the iris pupil is not dilated. Now let's quickly look into the layers of the iris. Then again, we'll come back to the iris topography. So iris has several layers. The first layer is the anterior limiting layer. Now this anterior limiting layer is not an epithelium, but it's an incomplete layer made by the condensation of the fibroblast and the melanocytes. Now, as the anterior surface of the iris is not covered by epithelium, so you can understand that the aqueous humor can freely penetrate the iris stroma. This is very unique characteristic of the iris. Now, the next layer is iris stroma. The iris stroma consists of fibroblasts, melanocytes, blood vessels, and nerves in a collagen-rich extracellular matrix. Now, these iris vessels have non-fenestrated endothelium, which maintains the blood aqueous barrier, which we'll be talking later. Now, one thing you must know that the sphincter pupillary, that muscle actually originates in the iris stroma and lies within the pupillary border. So, as I said, that there are a lot of pigments here. So the main pigments are melanocytes and the clump cells. These are the two pigmented cells present in the iris. Now, iris color is determined by the number of melanin granules within the melanocytes and the area they occupy. You have to remember, it's not the melanocyte count. It is the number of melanin granules and the area they occupy determines the color of the iris. So as you have read already, the lightly pigmented iris is blue and green because the longer wavelengths of lights are absorbed and the shorter are reflected. Now, sympathetic innervation during this fetal life plays a very important role because it determines the migration of the melanocytes. So that's why the patients with congenital Horner syndrome will have lighter iris. Now, you have to remember that certain drugs, for example, the prostaglandin analogs, can cause hyperpigmentation of iris. Now, here I want to just describe or discuss some important clinical condition. All of you know that the iris heterochromia, it has been classically described in Fuchs iridocyclitis. So, for example, the iris of the affected eye is lighter in color. So why this happens? This happens due to progressive atrophy of the anterior limiting membrane and stroma of the iris. Now, sometimes what happens, spatially, remember, this happens only in the light color iris, where severe atrophy of the anterior layer, anterior limiting membrane, and the stroma reveals the pigmented epithelium. Now, these pigmented epitheliums are dark in color, so the affected iris looks darker. So this phenomenon is known as inverted heterochromia. Also, you have to remember that when significant atrophy of the iris pigment occurs, sometimes they can give rise to the transillumination defect, which can be seen in various conditions, including advanced cases of Fuchs heterochromic iridocyclitis. But the most important point for the darker individuals in dark color irises, this change of this color is very subtle and may not be appreciated easily. So you have to rely on the various other clinical features. The one important such feature is the blurring of the iris crypts, especially at the collarete. For example, you can see the picture here. The blurring of the crypts is very important, and this particular characteristic in darker iris gives the iris a smooth velvety appearance. So in darker iris, you may not appreciate the iris heterochromia easily. You have to look for the other signs. Now, coming to the two pigmented epithelium, the last two epithelium, the posterior most two epitheliums are pigmented epitheliums. The first epithelium in that posterior side is the anterior epithelium, and the second one we call posterior pigmented epithelium. You have to remember, though we don't use the term pigment in anterior epithelium, both these epitheliums are pigmented. Posterior epithelium is heavily pigmented and appears black in microscopy. Sometimes during cataract surgery, if iris is everted, you can see the jet black color of the posterior surface of the iris. So dilator pupillae is a muscle which arises from the myoepithelium and extending from the iris root. So just to differentiate between these two muscles of the iris, the sphincter pupillae is 1 millimeter wide smooth muscle which is present near the pupillary margin. The dilator pupillae occupies the ciliary zone, mainly the stroma and posterior pigment epithelium. The sphincter pupillae helps in pupillary constriction, but more powerful than the dilator pupillae. And nerve supply, the sphincter pupillae is by the parasympathetic and dilator pupillae by the sympathetic through the long ciliary nerve. Now, there are certain pit-like depression in the anterior surface of the iris, which can be mainly found in the collarete, and this is called crypts. And sometimes these are names again the Fuchs. So sometimes it is called crypts of Fuchs. The anterior surface of the iris, as I said, these are not covered by the epithelium. So aqueous humor can freely penetrate through these crypts and enters the can easily enters the iris trauma. Now, few things you have to know when you will be examining a uveitis patient, that the iris nodules. Now, these iris nodules are the accumulation of the various inflammatory cells. Now, these iris nodules can involve the iris trauma and called Busaka nodules. The Kopis nodules are located in the pupillary margin. Now, there are certain cells like iris pearls. These iris pearls can be seen in conditions like leprosy, and these are small glistening white lesions that represents the aggregates of the very tightly packed living or dead lepra bacilli, which is lying in a mononuclear cell. So the iris pearls are basically the living and dead bacilli lying in the inflammatory mononuclear cells. Now, these are situated near the pupillary margin around the collarate. So the another deposits can be seen, which is far more common, is iris crystals. So these crystals are often called Russell bodies. They consist of immunoglobulin deposits and can be seen in chronic uveitis, including most commonly can be seen in Fuchs uveitis also. Now, one must differentiate, at least by, you should know how to what is the difference between the iris nodules and the iris granuloma. The difference is that iris nodules differ from the granuloma in that they are accumulated deposits of epithelioid cells and lymphocytes that have don't cause any tissue destruction. So the iris nodules, they don't cause the tissue destruction, whereas the iris granuloma, they are known to cause the tissue destruction. Now, coming to the posterior surface of the iris topographically, it is already, I mentioned, it is heavily pigmented and dark brown in color, and posterior epithelium can extend for the short distance in the anterior iris surface. As you can see here, we call it pupillary frill or pupillary ruff. You can see the color difference between, because this is the extension of the posterior epithelium. So this can be another example of this eversion, is that eversion of the pigmented posterior epithelium, which can be sometimes seen as a complication of long-standing uveitis and called atropine UV. Now, the nerve supply, coming to the nerve supply, iris is richly supplied with the non-myelinated nerve, mainly from the short ciliary and the long ciliary. Now, iris and ciliary body, the nerve are extremely sensitive to pain. On the other hand, the choroid, the other part of the uveal tract, is relatively insensitive to pain. That's why when we do the pan-retinal photocoagulation or other laser, we don't experience severe kind of pain. So now, coming to the nerve supply, I just want to just mention a very important point, that you know that the varicella zoster virus that usually affects the thoracic and trigeminal nerves. Now, this ophthalmic division of this trigeminal nerve is involved 20 times more frequently than the remaining two nerves. Now, this nasociliary nerve, which is one of the three main branches of the ophthalmic nerve, you must be knowing the other two. The other two is frontal nerve and the lacrimal nerve. Now, this nasociliary nerve innervates both the globe and the nose. So there is a very important point here, that we call it the Hutchinson sign. Now, what is the Hutchinson sign? That if you see the cutaneous vesicles at the side of the tip of the nose, or any skin involvement of the tip of the nose, that indicates that the nasociliary nerve involvement, and there is an increased likelihood the patient's eye may be affected. So this is known as Hutchinson sign. Now, coming to the blood supply, there are broadly two arterial circle which is responsible for the iris blood supply. The major circle of the iris is located at the root, which is formed by the long posterior ciliary arteries with communication from the anterior ciliary arteries, and this circle sends the radial vessels towards the collarete and forms the minor circle which is located in the collarete. You can see here, this is the major arterial circle, and it sends blood supplies and forms the minor arterial circle here. So the vein follows the same pattern and drains into ultimately the vortex vein, but you have to remember that they don't form the corresponding major circle like the arteries. So they don't form any major circle like the arteries, like major arterial circle. There is no such circle, venous circle in the iris. Now, few things when we are discussing about the blood supply, you must remember that the one thing is that the iris neovascularization, also known as rubiosis iridis, this can occur particularly in chronic inflammation and posterior uveitis, particularly when retinal perfusion is compromised. Now, this new iris vessel sometimes may be difficult to differentiate from the dilated vessel. As you can see here, this is abnormal iris vessels. Now, how to differentiate it from a normal iris vessel where the stroma or the anterior epithelium has undergone severe destruction following surgery, and you can see the normal iris vessel. So this can be actually the normal iris vessel actually courses radially, in contrast to the irregular distribution of the neovascular vessel. You can see here this vessel is not distributed radially. So this is how you can differentiate between a new abnormal iris vessels from the normal iris vessel. Now, you have to remember that sometimes iris vessels are dilated, and these are known as roseola and can be seen in syphilitic uveitis. Iris atrophy is a very diagnostic feature of herpetic uveitis and results from the destruction of the arteries. So sometimes it is the result of the endarteritis. That's why they lead to iris atrophy. But you have to remember that there are several other causes of iris atrophy. For example, anterior segment ischemia. It can be due to syphilis, leprosy, or most commonly it can be seen in previous attacks of angle closure glaucoma. Now, we have already gone through the anatomy of the iris. Let us just go to the uveitis. So what I'll do, I'll just discuss the pathophysiology of the uveitis with the help of a case of a iritis, which means the inflammation of the iris tissue. Now, 4 cardinal signs of inflammation were described by the 1st century Roman medical writer Celsus. So this includes the rubor, the Latin names are dolor, which means the eye pain, the pain. Rubor, it can be the congestion. It is calor, means the generation of the heat. The tumor, that means swelling. And the last one, the functio lisa, or the loss of function, was added later. Now, all these 5 can be seen in a case of iritis. It can have, the patient will have eye pain, the patient will develop the congestion, there will be increased generation of the heat from the warm iris tissue, and there will be swelling of the iris, and there will be loss of movement in the restriction of the iris tissue. Now, let's go ahead. During inflammation, the iris vessels which are dilated, and there will be breach in the blood aqueous barrier. So there will be exudation of the protein-rich fluid in the iris tissue spaces. So this can be perceived as a cells and flare in the anterior chamber. So clinically, when you pass a beam of light, you can count the cells using 1 millimeter into 1 millimeter beam, and you can actually count the cells, and that's how we grade the cells, which will be maybe discussed in the subsequent classes. So similarly, the amount of the protein in that aqueous, which is actually ideally optically empty, so we can actually compare the details visibility of the iris, and we can grade the flare in various grades. Now, this may be followed by the constriction of the pupil. Now, why the pupil is constrict? One of the reason is that hyperemia and dilatation of these radially arranged vessels will lead to the constriction of the pupil. Also, you have to remember that the chemical mediators which are being released from as a result of the inflammation will try to irritate these iris muscles. They will act on both iris sphincter and the iris dilator. But at this point of time, as I said, that the sphincter is more powerful, so sphincter takes over the dilator pupillae and there will be constriction of the pupil. Now, the inflammatory cell, which is in the anterior chamber, they will come across a convection current. Now, this current is primarily due to the temperature difference between the warm iris, the inflamed iris will be warm, and the cooler corneal surfaces which is continuously in touch of the atmosphere. So because of this convection current, the aqueous will rise in front of the iris and then falls near the corneal surfaces. So because of that, what will happen? There will be a peculiar scenario. Now the corneal endothelium, which is actually not getting the proper nutrition because of the turbid aqueous humor. So there will be desquamation of the corneal endothelium at several places. And this, because of the sticky nature of the corneal endothelium, the inflammatory cells were moving in the anterior chamber. They will be they will come and stick to the corneal endothelium. So this is what we perceive as a erratic precipitates, which is usually because of this convection current you see here, usually they form a base down triangle, which is known as Earl's triangle. Now, if the inflammation is severe, the effect of gravity will come and there will be sometimes this leukocytes will settle down at the bottom of the anterior chamber, giving rise to a condition which we called hypopion. Now, hypopion is a red flag signs in uveitis and you have to manage very aggressively. Now, as I said, that because of the unusually large amount of exudation and swelling, and because of that, iris will become a waterlogged sponge kind of tissue and full of sticky fluid. The movement will be impaired, and that's why you will see that the pupillary reaction is very sluggish or sometimes completely abolished in cases of iritis. Now, also because of this exudation, the fine pattern, as you can see here, the fine pattern will be lost, and that's why sometimes this kind of iris is called muddy iris. So this is all about the iris appearance. So now, as you can see here, the sluggish and literally immobile iris rest over the anterior lens capsule, and they may form adhesion between the iris capsule and the lens anterior capsule. And this iridolenticular adhesion is known as synechia. Now, if you start applying cycloplegic drop, then what will happen? In few places there will be the synechia will give away and it will give rise to a festoon pupil appearance. Now, there are various kind of synechia. So sometimes when the synechia involves the 360 degree, then we call it annular or ring synechia. Now, in cases where there is 360 degree synechia, but still you can see the part of the lens, as you can see here, we call it seclusion pupillae. And when there is a 360 degree synechia with formation of a membrane over it, then we call it occlusio pupillae. Like here, you can see here, you can't see the crystalline lens here, so we call it occlusio pupillae. So naturally, what will happen? This kind of occlusion will block the aqueous drainage through the trabecular meshwork. So there will be bowing of this iris anteriorly. So this again could give rise to the iris Bombay formation. And what will happen now? There will be peripherally this iris will come in contact with the corneal endothelium. So naturally, there will be formation of the peripheral anterior synechia. So there are several mechanisms, like it can have an angle closure and angle open. So IOP can go high in uveitis through several mechanisms. So an open angle can be blocked by the deposition of the inflammatory cells, which will clog the trabecular meshwork seams, so giving rise to the high IOP. Sometimes what will happen, there will be inflammation of this trabecular meshwork. We call it trabeculitis, a characteristic feature of the viral anterior uveitis. So this, what will happen, the seam will become very narrow, and this will offer considerable resistance to the aqueous outflow. So naturally, there will be a rise in the intraocular pressure. Now let's move to the place from where the aqueous will start originating. So let's come to the ciliary body. The ciliary body is divided into two parts, the pars plicatum and the pars plana. The pars plicatum is richly vascularized and consists of 70 radial folds that are known as ciliary process. This ciliary process secretes aqueous humor, and the pars plana, in contrast to the pars plicatum, it's a relatively avascular, smooth, pigmented zone, 4 millimeter wide, and extends from ora serrata to the pars plicatum. So that's why you see this is the site that's safe for the posterior surgical approach to the vitreous cavity. And that's why this site is approximately located 3 to 4 millimeter from the corneal limbus. Now, the ciliary muscles, if you see, I won't go into details of the ciliary muscles. They occupy the anterior 2/3 of the ciliary body. And there are three groups of these muscles and contraction of these ciliary muscles loosens the jonular fibers, increasing the convexity of the lens, which induces the accommodation for near vision and also regulates the flow of aqueous humor in the Schlemm's canal. So this is very important in uveitis, in the sense the pain induced by the exposure to the bright light in uveitis can be due to ciliary muscle spasm. The ciliary body is innervated by the trigeminal nerve, and the pain is caused by the irritation of the nerve endings by the products of the inflammation in cyclitis. So this is more evident in cases of HLA-BT27 uveitis and sympathetic ophthalmia. So often the patient will come to you and complain of ocular pain even when there is very limited clinical signs of uveitis. And this happens because of the very early cyclitis. Now the cycloplegic agents, the agents of choice for all cases of anterior uveitis, and these agents, what they do, these are basically cholinergic and antagonists which work by blocking the neurotransmission at the receptor site and the iris sphincter and the ciliary muscles. So the cycloplegics, they serve three purposes in the treatment of anterior uveitis. So all of you know that they actually reduces the hyperemia of the iris tissue, and also they permits the mobility of the iris tissue by dilating it. So they prevents the formation of the synechia. So now the lining of this uveal tract is very important for the postgraduate students. So I just want to highlight the few things that you have to remember. Both the ciliary body and the iris tissue has a double layer of epithelium. Now the anterior pigment epithelium of iris, it continues as a outer pigment epithelium of the ciliary body, which again continues as the retinal pigment epithelium. So next is the posterior pigment epithelium of iris, which continues as the inner non-pigmented epithelium of ciliary body and continues as sensory retina. So both you have to remember here, the basement membrane of the non-pigmented epithelium is continuous with the internal limiting membrane of the retina. Now, one thing you must notice is the term outer and inner in the ciliary body. Now, this outer here means that this pigment epithelium of the ciliary body is facing the ciliary body stroma. And this inner, that means that it is facing the vitreous. So don't get confused by this term when we use the term outer and inner while describing the pigment epithelium of the ciliary body. Now, the ciliary process are the most vascular region of the whole eye. The ciliary process has several layers, like internal limiting membrane, stroma, inner non-pigmented ciliary epithelium, outer pigmented ciliary epithelium. Among these layers, the non-pigmented epithelium is very important because they are the primary source of aqueous humor productions. Now, one of the most characteristic or important landmark here is the non-pigmented and pigmented epitheliums are oriented apex to apex, and this configuration is very important, and these are actually fused by the complex system of junctions and various cellular interdigitations. Now, the inflammation of the ciliary body can lead to inflammation of the vitreous and formation of snowballs. Now the snowballs are the aggregates of the inflammatory cells. As you can see here, the snowballs here. This is the clinical picture of the showing the snowballs. So these are the aggregates of the inflammatory cells in the inferior vitreous and consist of lymphocyte, macrophages, epithelioid cells, and multinucleated giant cells. Now, the snow banking, on the other hand, is the severe form of this kind of inflammation spectrum, as you can see here. And here you can see there's this yellow line here that I have tried to show the snow bank here. So what happens here? The snow banks, basically they are the membrane that consist of collapsed vitreous collagen, blood vessels, and lymphocytes. So this membrane can bring hyperplastic changes in the pars plana non-pigmented epithelium, which is responsible for the aqueous humor formation. So you can imagine, if you are not treating a snow banking aggressively, it can lead to protracted hypotony, because they have this snow bank, they can bring conformational change in the non-pigmented epithelium of the ciliary process. Now, the ultrasound biomicroscopy, as you know, it's a high frequency ultrasound device which uses 35 to 50 microhertz, and that allows the analysis of the retroiridal space and the pars plana, which we cannot examine clinically. So this is very important in the inflammation of the ciliary body. So though the ASOCT has taken over in anterior segment imaging, one important or interesting nuggets you should know, that the UPM scores over this ASOCT in opaque media because it can penetrate the pigmented epithelium of the iris. So that is very unique feature of that. So now coming to the attachment of the uveal tract with sclera, that uveal tract is firmly attached to the sclera at 3 places. So these are scleral spur, exit points of the vortex vein, exit points of the vortex vein, and the optic nerve. And choroid is firmly attached to the sclera at the ampulla of the 4 vortex vein, and this can be reflected in this choroidal detachment, which gives the total quadri-lobed appearance due to this kind of attachment. Now, the supraciliary space, I just want to highlight for 2 reasons. One is that this is a potential space located below the sclera and above the choroid and ciliary body. So it is now become very popular and attractive site for the drug delivery because it targets the choroid and it continues at the supraciliary suprachoroidal space also. So the retinal pigment epithelium and retina, with the high bioavailability of the drug maintaining elsewhere in the body. So as the supraciliary space can accommodate fluid, so it has been tried various, some are in experimental stage. This space has been tried to inject the drug, sometimes in microstents, like various glaucoma, like MIGS kind of procedure. It is being tried as a potential space, and you should know about this space. Now coming to the third layer of the uveal tract, the choroid. The choroid is the primary vascular layer of the eye. The choroid has highest vascular flow rate in any tissue in the body, and up to 85% of this ocular entire ocular flow goes to the choroid. 10% goes to the ciliary body, mainly the ciliary process. 4% goes to the retina, and 1% reaches the iris. Now, choroid is the thickest and most vascular in the posterior pole, and it is thinner and less vascular at the anterior and equator. So that's why when the transscleral drainage of the subretinal fluid is performed during the retinal attachment surgery, the sclerotomy is usually made at or slightly anterior to the equator near the 3 o'clock or 9 o'clock meridians. So these are the location where they are far away from any major vortex vein and relatively little less vascular than compared to the posterior. So now choroid is composed of several layers. Let's go one by one from the RPE side. So beneath the RPE, there lies the Brooks membrane. So Brooks membrane, as you know, I can highlight it here. It is made up of 5 layers. It is actually bordered by the basal lamina of 2 structures, the basal lamina of the RPE cells and the basal lamina or basement membrane of the choriocapillaries. In between that, there are 2 collagen layers, inner collagen and the outer collagen, and between them, there is elastic layer. Now, this elastic layer of the Brooks membrane confers the biomechanical properties. It is responsible for the vascular compliance, and it has some amount of the angiogenic barrier functions, and it is actually discontinuous in the macula. Perhaps it may partially explain that why the choroidal neovascularization little more common in the macular area. Now, coming to the most important layer of the choroid, like the choriocapillaries. The choriocapillaries is composed of a monolayer of the capillaries, and it is immediately next to the Brooks membrane. The unique characteristic of this choriocapillaries is that it has a very wide lumen compared to any capillary beds in the body. You compare it with any capillary bed, the choriocapillaries capillaries have a very broad lumen, and so broad that it can permit several erythrocytes to pass through simultaneously compared to other capillaries elsewhere in the body. So choriocapillaries are very unique in nature. Now, coming to this settler layer, which is actually the medium-sized vessel layer. So it's composed of the medium-sized vessels, the prominent melanocytes, macrophages, lymphocytes, mast cells, and fibroblasts. And within this layer, the transition of the arteritis to arterioles starts, and the arteries gradually lose the tunica media and the internal elastic lamina, while the tunica adventitia actually slowly make a collagen, they become a collagenous layer, and the vessels here are also non-fenestrated, so that's why they don't leak the fluorescent angiography. So similarly, Haller's layer, here, it is just like a normal similar vessels like the rest of our body. The vessels are very large diameter. So that's why we call it's like a large vessel cell layer. And these vessels are also not non-penetrated. Now, just when we are discussing about that, I just want to highlight one applied aspects of this, that the pachychoroid is relatively newer term. It's a state of the focal or diffuse increase in the choroidal thickness. It accounts for the dilated choroidal vessels in the Haller's layer, which is often called as a pachy vessels. And this accompanied by the thinning of the choriocapillaries and settler layers with or without our retinal pigment epithelium abnormalities overlying the pachy vessels. So I think in subsequent classes, there will be more discussion on this topic. So I'm not going into that details. So coming to the blood supply of the uveal tract, because it's a very important postgraduate question. So I have put 2-3 slides on that. So the blood supply of the uveal tract comes from the posterior ciliary vessels and the anterior ciliary artery. The posterior ciliary vessels include 10 to 20 short posterior ciliary arteries and 2 long posterior ciliary arteries and anterior ciliary arteries. Now, coming to the short posterior ciliary arteries, there are 10 to 20 such arteries which enter the sclera to form the anastomotic ring. We call it circle of the gene or Haller. So this gene, just a trivia here, the gene actually was basically a botanist. Most of you have heard the name or know the name of the flower Genia. So this is named after him. So this botanist, he described several anatomical, he has a lot of interest on ocular structure. So he has described a lot of anatomical structure. You know them by this eponym, the gene. So this is the circle. It's called the circle of gene. So this supplies actually the anterior optic nerve and the posterior choroid. Now, coming to the long posterior ciliary arteries, here I have just drawn the posterior posterior artery so that you can see the artery without any other arteries. So what happens? It perforates the sclera, medial and lateral to the optic disc, runs forward in the suprachoroidal space, and then anastomose in the anterior ciliary arteries and supply the iris ciliary body and anterior choroid. And as we have discussed, they form the major arterial circle. We'll see in next slides, and then supply the iris. So this is about the anterior ciliary arteries. There are 7 such arteries. So they provide the major blood supply to the anterior uveal tract. The 2 travels with each rectus muscle. The lateral rectus is the unlucky one, which has only 1 such artery. These arteries, they pierce the sclera anteriorly, and then they fuse here with the long posterior ciliary arteries, and they form the major arterial circle. So they come like this, and then they join, they form the major arterial circle and supply the anterior uveal tract. Now, in addition to forming this major arterial circle, the anterior ciliary artery is also important. Why? Because they supply the sclera and the conjunctiva by giving the conjunctival branches and forming the superficial and deep episcleral plexus. So these plexuses are very important, as you know that in episcleritis, the superficial episcleral plexus are involved, and whereas in scleritis, the deep episcleral plexus are involved. So you can do a simple test with the phenylephrine. If you put phenylephrine, if it blanches, then it means that these are the superficial episcleral plexus, because it blanch with that. It's located posteriorly, whereas the deeper episcleral plexus is located beyond beneath the episclera, and they don't actually blanch with topical phenylephrine. So another very important question for the examination for the postgraduate student, the blood-ocular barrier. The blood-ocular barrier is a physical barrier which is located between the local blood vessels and most part of the eye itself, and stops many substances, including some drugs also, from traveling across the ocular tissue. So this first one is the ocular blood aqueous barrier, and the second one is the blood retinal barrier. So the blood aqueous barrier is actually comprised of tight junction of the ciliary process, the non-pigmented epithelium, the endothelial cells in the iris vasculature, and also it is present in the inner wall endothelium of the Schlam's canal. So now coming to the blood retinal barrier, there are 2 types of blood retinal barrier. One is inner and another is outer. So the blood retinal barrier regulates the fluid and molecular movement between these ocular vascular beds and the retinal tissue. And it's very important as it prevents the leakage of the fluid into the retina and potentially the harmful agents. So we'll see the most important clinical implication of this is that the macular edema, which can be seen in uveitis also. So where what happens, this uveitis, the macular edema, first of all, the macular edema is a non-specific sign. It can happen in it can occur in many conditions. So uveitis or inflammation is one of the most important cause. So it can result from the breakdown of the inner and outer retinal retina barrier due to the uveitis. And you have to remember both the duration and severity of the uveitis plays an important role in the causation of this uveitic macular edema. So what happens here? Release or diffusion of the inflammatory cytokines from the inflammatory side can damage the function of the retinal cells, vessels, and retinal pigment epithelial cells, which results into the leakage of the fluid into the retina and accumulation in the macula. So on top of that, what happens? This inflammation leads to the weakening of the RPE pump, the retinal pigment epithelium pump, which pumps out the fluid from the retina. So the detailed discussion about the retinal anatomy will be beyond the scope of this applied anatomy of uveal tract. So I'm not going into the details. I'll just finish with a very important physiology of the retinal tissue, which has implication in very important investigation in uveitis. So this is about this diagram. Just look at this diagram very carefully. So this is all about the lipofuscin in the retinal pigment epithelial cell. So you have to see that the retinal pigment epithelial cell, they phagocytose this tip of the overlying rod and cones. So what will happen? The one after one disc, they will be engulfed by this retinal pigment epithelial cells, and these will be known as phagosomes. These are progressively degraded intracellularly by the action of the lysozymes, and these breakdown products are then recycled and incorporated into this photoreceptors, from the photoreceptor cells to the RPE through the choriocapillaries. So this keeps happening under normal physiology. So when there is an inflammation, or with the increasing age, or when the RPE health is hampered, so this system becomes less efficient, and the breakdown products may accumulate in the RPE cells as lipofuscin. So the most important practical implication is the fundus autofluorescence, where it's an imaging technique, the non-invasive novel technique, where we can see the lipofuscin granules in the RPE cells, and we can actually have an idea about the health of the RPE tissue, and that gives actually further informations. So that's all for today. I hope it was useful for my postgraduate student friends. I would like to thank my postgraduate student, Dr. Divyansh, who had helped me in doing some kind of research and searching the literature for these presentations. Thank you. Thank you so much.
Thank you, Dr. Partho, for giving a very broad overview of the important anatomical features of the eye, as well as about the blood supply, and you touched upon the blood-retinal barriers and blood-aqueous barrier. I think it's a very vast subject, and nobody knows where it starts and where it ends. But you have tried to cover and give a broad overview, as well as given some basic information why the color of iris is blue and why is it brown. Okay, and I think there is a question on that. Who's got the questions? Rolika, you
yes,
got?
Abhilasha, ma?
Abhilasha, yeah, please.
So thank you, Dr. Partho, for this excellent lecture. And I'll be reading out the questions one by one from social media. So the first question is, what may be the reason behind hyperpigmentation of the iris with the use of PG analogs? So this doesn't really relate to uveitis, but
no, it's a very important question, because it touched upon the content of the melanin in the melanocytes, which gave the color. So the prostaglandin analogs like latanoprost, so do they cause increase in melanin granules, or they cause proliferation of proliferation? So that is the reason why. This important thing is that it is the blue or light colored iris which will get darker with the use of prostaglandin analogs over a long time, rather than the brown iris getting still darker. Am I right, Partho? Or
yes, sir. You are absolutely right.
The collateral to this would be hypertrichosis. Some people might like to have long eyelashes, and prostaglandin analogs do cause hypertrichosis, and that is seen typically in the opposite, the brown iris rather than the blue iris.
Correct.
But one important question, I don't know, Abhilasha, you have any further questions on still more?
There are 5 questions.
Yeah, please go ahead.
So the next question is, can iris nodules and granulomas coexist?
It can exist. I have seen, but I'll ask Professor Gupta to answer.
Yeah, sure. I mean, it's a the way you put it. Finally, a granuloma and a nodule is an exaggerated form of a granuloma. So essentially, it's a collection of the inflammatory cells. So if it is visible, it will be visible on the slit lamp exam as a nodule, and granulomas you would be seeing most likely only on histopathology. And but granulomatous scapes, for instance, can be seen at the back of the cornea. and they may have that waxy appearance, 3D appearance as we call them. So they are also kind of micronodules. So it's a, I think, difference in appreciation of the size, whether it's a granuloma or it's a nodule. Something
But
which
I think I've seen them together and they melt with topical steroids within a day together. They
yeah,
just melt away.
yeah. It's the
So
same thing.
yeah, they're basically same thing.
So we'll move on to the next question. Can you please explain about blood aqueous barrier? But I think we can skip this because Sir Dr. Partho explained it in detail. And so the question is the presence of flare an indication of active inflammation? So who would like to answer? Ma'am, you'll answer.
The presence of flare, you know, flare means the presence of proteins. Proteins means normally, you know, that's where the question of blood aqueous barrier is important, because all the barriers in the eye make eye the absolutely an immune privileged site. It doesn't allow any extraneous elements, including macromolecules, which are the proteins, the albumin, to enter into the ocular chambers, be the anterior segment or the vitreous cavity. It doesn't allow these molecules to enter, macromolecules. Okay, so only the micronutrients and oxygen would diffuse through to nourish the internal structures, you know. So if the proteins are present in the anterior chamber as flare, as we see them as flare, and which incidentally can be measured these days with the laser photometer or laser flare meter, as we call it. And you can actually measure number of photons per second. So I think it is a measure of the breakdown in that barrier because of either acute inflammation or chronic inflammation. So it cannot be by any stretch of imagination a normal finding. You know, presence of proteins in the aqueous or vitreous is not a normal finding. Okay. So sometimes, you know, there has been debate whether we should tolerate any inflammation, 1+ inflammation or flare in the eye, or we should not tolerate. Well, it's a question of individual people, how they look at it. In the past, they said we shouldn't tolerate, we should tolerate mild inflammation or mild flare. But these, I think, people do not like to wait for mild flare to exist, because it's not a good idea to have even a mild leakage of proteins into the aqueous.
Thank you, sir. I'll ask the next question. How do we differentiate between hypopion and pseudohypopion?
Yeah. So what's a hypopion? Is a collection of cells. And when it's not a collection of inflammatory cells, but say like it's a collection of fibrin. Okay, so it will be a kind of a pseudohypopion, or if it's a collection of malignant cells, and very often the infiltrative retinoblastomas, you know, they were present only as what we call pearly white, you know, kind of deposits in the anterior chamber, which are not exactly, and we have seen leukemias presenting, you know, so it's again a question of semantics, you know, hypopion or pseudohypopion, what you wish to call, you know, there could be necrotic brown pigment, there could be, you know, the blood there could be a blood mixed with inflammatory cells. So layering of cells, you know, mixed with fibrin, with proteins, you know, there can be a variety of these cellular deposits. So typically hypopion will call when there is a predominantly leukocytic or inflammatory cells, they're getting deposited in the anterior chamber.
Thank you, sir. And before we end the program, just one last question. Reason for hypochromia of iris in juvenile xanthogranuloma? Reason for hypochromia of the iris, hypochromia in juvenile xanthogranuloma?
This is little difficult to answer for me, but I guess the juvenile xanthogranuloma is something called due to polyclonal, that proliferation of cholesterol containing factors, you know, like some histiocytes. So there may be a reason for that, but I have to check on that.
I think probably the same mechanism which is acting on the cutaneous, the same thing which is happening in the iris.
True.
Well, I would just like to say one thing. Partho sir, I would like to disagree with you on one thing. You said that your diagrams were really not good. That was you being extremely modest because those diagrams were excellent. You said that they were not professional at all. I think they were way better than what we see. So thank you, sir. And you have very neatly outlined them and classified them. And if at all in fact, those are easy to replicate as well. So if at all the postgraduates look at them, and if you have that in your answer, you don't need text. So if you nicely put a diagram in and around it, everything that you can put across. So Partha sir, I'm disagreeing with you.
Thank you.
Right.
I think Partho, you were amazing. So elaborate and so to the point. Perfect.
Thank you. Thank you, ma'am. Thank you.
Thank you so much, everyone, for the wonderful class, sir, and for the wonderful discussion. Professor Amod Gupta, sir, Reema ma'am, and Abhilasha ma'am, thanks a lot for your contributions. Actually, these discussions mean a lot. They'll end up making all of us and even the postgraduates think about the topics and their aspects and applications. So thanks a lot. And as we have started this session, we will now move on to the epidemiology and classification that will be on December 7th by Dr. Samira Nayak. And we will all see you there. And don't forget that physical eye focus, you can still register. And we will be having the physical eye focus in February. It will be 26th of February to March 5th. And all the delegates who are interested are required to register. And we are looking forward to meeting everybody there.
Well, thank you all.
Thank you, sir.
See you on Wednesday.
Thank you.
Thank you so much.
Thank you, Reema ma'am. Thank you, Partho sir.
Thank you, Partho.